Hi, I'm Shiv Gaglani, welcoming you to Raise the Line with Osmosis from Elsevier, an ongoing exploration about how to improve health and healthcare. I'm honored to do that today with Dr. Andrew Cameron, the Surgeon-in-Chief of Johns Hopkins Medicine, the Director of the Department of Surgery at the Johns Hopkins University School of Medicine, and Chief of the Division of Transplantation. Within these roles, he directs all surgical subspecialties and leads the abdominal transplant team. As a professor of surgery, he has an active surgical practice in treating alcohol-associated liver disease and hepatocellular cancer, and maintains an NIH-funded research laboratory studying severe alcoholic hepatitis. Dr. Cameron's scientific interests focus on improving access to and outcomes after organ transplantation for those with end-stage liver and kidney disease. He has initiated novel efforts utilizing social media, leading to a significant increase of awareness of organ donation online, and most recently has led the effort at Hopkins to explore the use of genetically modified animal organs as a solution to the organ crisis. Dr. Cameron serves as a member of the National Advisory Council on Alcohol Abuse and Alcoholism, has authored over 140 scientific articles and book chapters. He's also the co-author with his father, John Cameron, of Current Surgical Therapy, 14th edition, published by Elsevier. And I've had the distinct pleasure to meet with Dr. Cameron on a semi-weekly basis as I just finished my surgery clerkship, and it was honestly one of the highlights of my entire med school experience. So Dr. Cameron, thanks for taking the time to speak with us.
Shiv, good to see you again. Thanks a lot for having me on the show.
For sure. And one thing I was really impressed with by the surgery clerkship as a whole, and you in particular, was how much time you spent with us as medical students talking to us about how to, what got you guys into surgery and medicine as a whole. So for our audience who may not have heard your story, can you just tell us a bit more about your background and your path into medicine and then ultimately liver transplantation?
Sure. I mean, it's no surprise that we spend time with med students at Hopkins. It is one of the most important things we do down here. It is sort of the lifeblood of the place, and it keeps us all young. So I was a Hopkins med student. I was born and raised here in Baltimore and went away for college, but came back for the experience in med school here and got interested in surgery and have been doing training in Boston and in LA, and then have been back on the organ transplant team at Johns Hopkins for almost 20 years now. And, I think like some people in medicine, I had an early exposure, which was formative. And for me, it was my father. My dad's a doctor, and he was a doctor here at Hopkins. And I can remember walking around with him in a mall or at a grocery store. And somebody would come up and stop him and say, you're John Cameron, you saved my wife's life. And as a little kid, I didn't know what was going on, but I knew something important was going on. And I knew it was something that I wanted to learn more about. And as I grew up, it was like a kid, you're interested in baseball, you like playing baseball, and then one day you figure out your dad's Cal Ripken. And so I was very interested in medicine and got exposed to it in a more meaningful, sophisticated way in college, got into laboratory research, and here we are.
Yeah, no, it's quite the story, and very relatable too. That's actually partly what got me into medicine. Was my dad's a retired doctor, and I used to go follow him to the hospital and also not really understand what he did day to day, but understood how he made people feel and the gratitude they had and respect, etc. So for those who don't know, and very few will not after this, Dr. Andrew Cameron's dad, Dr. John Cameron, helped perfect the Whipple procedure for pancreatic cancer and also was surgeon-in-chief at Johns Hopkins. So I'm curious, did you guys ever get a chance to operate together? I'd love to hear if there are any interesting stories you have from that.
Oh, yeah. Oh, yeah. So when I came back on the faculty, I'm a liver transplant surgeon. And most of the surgical oncologists, which is really what my dad was, he was a cancer surgeon. He helped people with pancreatic cancer. They spend their lives trying to avoid the portal vein, which is a big vein in your abdomen, bringing a huge amount of blood back from your intestines to your liver. And if you get into the portal vein, it's nothing but trouble. Liver transplant surgeons spend their whole career messing around with the portal vein. So every once in a while, I would get a call, sometimes a hectic call from the operating room, that my dad or one of the other pancreatic surgeons was doing a Whipple resection and had gotten into the portal vein, and could I come running over? And so in an unusual role reversal, I'd be able to go over and help. And being able to help is what a doctor wants to do. And, we try and help our patients. We try to help our students understand. But when you have an opportunity to help your father, who has been, the Superman in your life, that was a treat. And you had to briefly stop yelling and cussing, and I got to pitch in, and most of the time it turned out okay. It was sort of a role reversal from when he taught me how to drive stick shift.
That's that's awesome. I think those are the experiences you never forget. Probably the first time
Yeah,
you operated with him. And I'm curious, so you were interested in medicine, kind of following the footsteps. And then you went into surgery. I get that, but then your path's diversion. You chose to go into liver or transplant. How'd
yeah.
you make that decision? And maybe walk us through that.
I was a med student. I was getting involved in some basic science research that had to do with immunosuppression. I got a chance to be on the transplant service like any other Hopkins med student, and I remember being told I could get to go on an organ procurement. We flew to Oxford, Mississippi. I remember it like it was yesterday. We stayed up all night getting a liver, brought it back, stayed up the next day sewing it in. This is 24 hours into it. I'm dead tired. I just want to go home. The case is finally over. We get to go home. No, they're not going home. They're all going out to Alonzo's to get a hamburger. And we sit at this bar eating a hamburger. We've been up 24 hours, and they keep talking about the case and about transplant and about the patient. And it occurs to me this team doesn't know the difference between work and play in a good way, that this is just their lives. And I thought to myself, I want a job which is not a job. I want a job which is just a life endeavor that captivates me so much that it's just an exciting, worthwhile 24/7 plus. And so that I caught the transplant bug, and it had a lot to do with science, and it was a growing field. It was rapidly changing, and it became my own thing, distinct from, what he was doing in cancer.
Yeah, no, that's fantastic, and I think very relatable to those listeners of ours who chose specialties based on kind of the culture, the team that they've met, and I think you were the one who shared with us some advice, and I'll ask you about more advice at the end of this around also wanting to love the bread and butter cases, not just the most exciting cases that you'd see, but the bread and butter, that the things that you'd be seeing or helping 70-80% of the time as a insert specialty choice here.
And I'd add to that, love the patients too. So love, the disease processes that are going to be of interest to you, the patients you're going to see in clinic every day. You're right. It's not only a big, exciting, dramatic surgery. It's taking care of this person and their disease process, how it affects them up to the operation. Sure, the operation for sure. And then after it's like a journey, and it's this long journey. And these are the people you are going to be spending your life with in clinic, the late night call, the coming in on the weekends. And so make sure, that that's your group of people that you want to commit to and dedicate to your point, more so just than I like that one operation.
Yeah. No, totally, totally. And as you mentioned, it's a field where you can get involved at the very micro level, like the basic science research, all the way to the policy. And as I made clear in your intro, you've done work on both spectrums. So maybe let's start with kind of the basic science work that you do, the xenotransplantation. What got you interested in the basic science, getting your PhD, running an NIH-funded lab, and then we're going to zoom out to talk about maybe the policy changes with organ transplantation that you're helping lead to or you've helped work on.
Sure. So, organ transplant is exciting, and it's exciting because it's powerful and it's successful and it saves people's lives. And it takes people that are often certain to die, some of them certain to die this weekend without a transplant, and it restores them to good health. There are guys that play in the NBA after a kidney transplant. There's a guy that won a gold medal in the Olympics, snowboarding after a liver transplant. So it's a bit miraculous. And in fact, it's a victim of its own success. There aren't enough organs to go around. So most of what we do in terms of research now is trying to discover new sources of these life-saving organ transplants. And that's been going on for decades, certainly preceding me and all during my time coming up through the field. There is a a revolution on hand right now, in which, after years of struggling to locate a new source of organs, there may finally be an answer. And that answer, to everyone's surprise, is animal organs. And pigs may save the day. It may be that hearts, kidneys, who knows, livers from pigs will be the answer to the organ shortage crisis. And that is only because now, with the discovery of CRISPR-Cas, we can easily genetically modify pig genomes. So that there are now pigs out there with 10 genomic edits, 4 gene knockouts that make them less pig-like, 6 human gene knock-ins that make them more human-like. And those pigs now, for the first time ever, are probably becoming acceptable sources of organs for human transplants. And that is going to change the world. And the world, we should get together again in 10 years. The world is going to be a very, very different place. And it's awfully exciting.
Yeah, and I saw the press release from Hopkins maybe I think a year or two ago that you and your collaborators here at Hopkins got a $21 million NIH grant to do that. Can you talk a bit about specifically what your goals are with this current work?
Sure. So, enter these interesting pigs as donors, and, are we ready to push ahead into this brave new world? So to make sure that it's going to be safe, that it's going to be effective, if it were my family member or loved one, are they ready to get a pig organ? We need to test this. And to test these organs, the best way to test them is in animals, to do a transplant that simulates a human transplant. And we are collaborating with industry and others to test these organs. They look like they are going to be reasonable, solutions to the organ crisis. They look like they're going to work. Fast forward now, the University of Maryland has done 2 heart transplants into patients that needed a heart. One was not available. They used a genetically modified pig heart. And then just last week, days ago, the field is moving so fast, it's hard to even keep up. Our colleagues at Mass General took a genetically modified pig kidney and transplanted it. And it looks like that organ is working indistinguishably from the way a human transplant would work. And this could really be a game changer. There are 100,000 Americans on an organ transplant wait list today. Today, 20 people will die waiting for a transplant, not because they have something modern medicine couldn't figure out, just because there aren't enough organs. We could save them like that if we had the organs. Well, farms of pigs that have been genetically modified to be excellent organ donors may save those 20 lives a day.
Yeah, no, it's truly inspiring. I think one of the reasons you come to a place like Hopkins is to learn from people like you who are pushing the field forward. And you gave a really wonderful talk about this problem to our surgical clerkship, I think our last day of lectures. And you also mentioned, kind of the ethics around the market solution for organ transplants. So for our audience who may not be as aware of this, can you tell us about how you think about that as a solution, getting more people to be organ donors, maybe creating a market for organ donations? Any high level comments on that? I know we could spend hours talking about it.
Well, I'm agnostic towards these solutions. I've got patients dying on the wait list. I'll take these organs however I can get them. And I can think of a number of possible solutions off the top of my head. We certainly didn't start with animal organs. We have a lot of wonderful, generous people in the United States who agree to donate their organs, after they die. And that is an excellent source of life-saving organs. There are people who are living donors in the United States. It may be for a loved one. It may be for somebody they knew in high school. Who knows? There are multiple possible sources of the organs, but the one thing's for sure, there aren't enough. So one possible solution is, and this is maybe getting far afield, but let's view these organs for what they are, a valuable commodity. And commodities in markets have a value that can be assigned to them. So we could imagine compensating people for donation. Now, this flips the field on its head. Normally, it is an act of generosity for which one expects and receives no specific compensation. This would be different. This would be saying there's not enough of this commodity to go around. The way we solve most market shortages is by raising the price one's willing to pay for that. Now, this is complicated because it's not a typical commodity, it's a human body part. And these are lives in the balance. So we would have to imagine a scenario in which very carefully evaluated patients donate both because it's the right thing to do and it's a life-saving gesture, but also receive some type of fair market compensation. There is then an increased supply of donor organs, which are then distributed by the government or the hospitals to those at the top of the list. So we would avoid any problematic transaction between a needy patient and a donor. And we would avoid this notion of transplants for rich people or vulnerable folks being taken advantage of to sell their body parts. It is an idea whose time has not yet come to the United States. It is but one of many possible solutions to the organ shortage crisis. We could, as you say, we could talk for hours. It leads maybe back towards the simplicity of other solutions like animal organs, in which we wouldn't have to worry about people feeling a financial pressure or compulsion to donate, which makes a lot of people nervous.
Yeah, no, and I know these are some of the high level discussions, and I'm curious, what type of things have you or your team done? Like I'm sure you're often asked to speak, and you gave a great TED talk, I think last year, which we'll post the links in the show notes about the xenotransplantation frontier. But what types of ways have you or your colleagues directly gotten involved?
Sure. So, I mean, Shiv, if you needed a transplant, you'd get one. There would be 20 people that would come forward to donate by the end of this podcast to donate to you. If my daughter
Sure.
needed a transplant, there would be a fist fight breaking out for who gets to donate to my daughter. And that is because solutions come from us taking care of us, from communication and sharing. Where I think we fall short, where there are people on the kidney transplant wait list waiting for 10 years, dying on dialysis, is a failure to communicate. It's not that they don't have people, they don't have daughters and friends and people that love them. It's that we as healthcare providers haven't done a good job helping them get their story of need out. So we utilize social media in a very simple way to help people tell their story. We gave people an app which we developed, which was really simple, and it allowed them to post their story. Everybody's got a phone. Everybody knows how to post on social media, more or less. Maybe it's something you do 5 times a day for things that aren't that important. But you could use the app to say, hey, you may not know this about me. I'm on dialysis. I've been told I need a kidney transplant. If you want to learn more about this, click here. If you want to pursue maybe being my donor, reach out to my hospital, click here. With just that trivial app, folks that use that app at Johns Hopkins were 7 times more likely to have a donor come forward than a group of comparable patients on our wait list that didn't use the app. There were folks that downloaded the app, made a post telling their story, and had 5 people volunteering to be their donor in the car ride home. So solutions are out there, and we need to do a good job giving voices to people that are sick and vulnerable and don't have voices, so that they can avail themselves, of the possibility of these life-saving transplants. Many possibilities are out there, for how we can do better to help serve our patients. And, we've covered the ground already of 3 or 4 of them, and there are probably more that we haven't even thought of.
That's really incredible. And again, I'm in awe of the multi-factorial solution that you and your team are pursuing, ranging from app technology to CRISPR based xenotransplantation. I think it's pretty awesome. And so, I love also from your stories how you put things in context, especially historical context. And again, for those who don't know about the chair that Dr. Cameron has, his father held it as well, who helped perfect the Whipple, as mentioned before that. A couple people before that, it was Dr. Alfred Blaylock, who helped basically bring forth the field of cardiac surgery. If you haven't seen Something the Lord Made, it's a wonderful movie that I saw for the first time, actually, only a couple of months ago before starting the surgery clerkship, and posted about it. And then before that, I think the original was Dr. Halstead, one of the four founders of Hopkins, who, among other things, helped develop the radical mastectomy for patients with breast cancer. And then I was even in clinic with Dr. Pat Walsh, who was on the urology. He ran the urology department, who speaks the world of you, by the way, Dr. Cameron.
A good
Who's a
friend.
big fan.
I,
Yeah.
I was a medical student with Dr. Walsh as well. So the big
Yeah.
wheel takes one more spin.
He's 86, still seeing patients. I was in clinic a couple weeks ago. It's amazing. And he helped make the radical prostatectomy as we know it, the neurovascular nerve bundle sparing surgery. So this is the context of where we've been, or at least where Hopkins surgery has been, which has affected global surgery. What gets you most excited? Obviously, we talked a lot about organ and liver transplant, but what gets you most excited about where we're going? What's the next big race and field?
Yeah, so we've talked a little bit about what gets me excited. Maybe it's organ transplantation or it's meeting this unmet need, but that's me. What gets me excited is what gets everybody else excited. So I meet with young people and I say, what are you interested in? And they go, well, I'm interested in psychiatry. I'm interested. Okay, why? What is it? Who are your mentors? What are the unmet challenges in psychiatry that prevent you from sleeping at night? And people will say, well, you know what? We do a really terrible job, with eating disorders. And let me tell you why I'm interested. Then I'm pumped up. And so somebody will say, well, I'm interested in emergency. Well, tell me about emergency medicine. What is it about that? So it is young people identifying their passion. We forget me. I'm okay over here, but what about you? And what is it that you have seen that worries you? What is it about the unmet clinical need that you have discovered that annoys you? We don't do a very good job with Crohn's disease. We don't do a very good job with vascular trauma. Hit me. Let me know what it is that you have seen that you think it would be worth spending your life trying to fix. Because we only get one. We're only going through once, but you get to pick. And so you're going to see a lot of patients, a lot of unmet clinical need. You get to pick. And I love to hear people explain it to me, why I should have gone into ophthalmology or why they are making the right choice by going into neurosurgery. And I'm very easily swayed. You know, I'm thinking of doing it all over again.
Yeah, I mean, you're still very young. I mean, your father was still operating until what, his 80s or 70, at least 70s.
Sure enough, and I mean, you look around, the changes seem to be accelerating. I'll tell you one thing that gets me really excited is non-surgical. The recent developments we've seen in weight loss drugs are going to change the country in, I think, a really wonderful way. There is a pandemic of obesity in the United States. Now, it's interesting because 20, 30 years ago, there were some very effective surgeries developed to treat obesity. And from those surgeries, we learned a lot about endocrine metabolism of satiety and obesity. And from that, we've been able to develop drugs. And now some of these incredibly potent drugs are able to effectuate almost the same weight loss as the surgery. And I think that is really going to change, you know, the health profile of the United States in a really exciting way. So I could be talked into young people going into endocrine and hopping on the incredibly exciting bandwagon of the changes that are going on with obesity management.
Yeah, no, it's definitely the hot topic. I've had already a couple of different grand rounds and lectures around that. I think even the surgery department, which I'll praise, having only done a couple of different rotations, I'm very impressed with a couple of things. One is the grand rounds that brought in people like we had Dr. McKinnon on this podcast as well, who I met through you,
Great.
who and obviously a very world-renowned plastic surgeon who did the first allotransplant for nerves. Spent her grand round talking about the importance of changing the culture of surgery. And then I remember one M&M report you led where, these gods, right, the surgical gods that have been treated as such and for good reason for many decades, kind of very humbly open up about things they could have done better. And so the culture seems really, from outside in, seems very, I don't know, I was impressed with it. I don't know if you feel the same way.
M&M culture is something that's been developed and cultivated in surgery, for a while. I don't want to say it's unique to surgery, but I think we have a high commitment to it. And that's this notion that you all in the room don't have to make every single mistake that I have made. Let me tell you about what didn't go perfectly in this patient's care. And to do that, we all have to agree, if you will, that that is a safe space. I'm going to tell you about a mistake I made, or at least I'm going to tell you about a way in which this case didn't go perfect. It may or may not have been an error or a shortcoming on my own part, but at any rate, it didn't go perfectly. And I think when we all commit to sort of rigorous self introspection and improvement, it's bound to be a good thing. And I can sit there and listen, and I can accrue experience and knowledge and judgment, not having to have a patient go through, the sequelae of a medical error. And I think we can be creative, and I think we can talk about exciting new medicines that might put us out of business, doing surgical weight loss procedures. That is exciting if you are approaching it from a patient-centered perspective. We're not here for me to do fancy surgeries. We're here to take care of sick people. And if there is something that is going to help us take better care of sick people, it might be a new operation. I want to hear all about it, or it might be non-operative. And if it's better for the patient, we're all in on that too. And I think with that approach, surgeons will remain relevant regardless of what they're doing with their hands.
Yeah, I agree. And obviously, having now scrubbed into several surgeries, I think it's a long way until we'll have autonomous robots doing surgeries, especially ones that are acute, like trauma or transplant in many cases.
The robots are an important part of developing technology too. So Hopkins has the largest fleet of surgical robots in the country. We've just done our 20,000th robotic procedure. Over 50% of the surgeries at Johns Hopkins are done robotically. So are robots going to be doing the cases? No, I don't think so. But are surgeons going to be better at what they are currently doing because they are using robotic technology? For sure.
Yeah, no, for sure. And you've entertained me with a lot of thought-provoking stories. One story I'll tell you that I think you'll appreciate, because I don't think I was able to tell you during our preceptor groups, is I was in Dr. Ghazi's surgery, a robotic assisted nephrectomy, partial nephrectomy. And one of the people right next to me who's just there watching it as well, we struck up a conversation. He's a 24-year-old PhD student in the computer science department. And Dr. Ghazi has done a great job of kind of reaching out to the Whiting School. And this student's PhD is about how do we train a vision language model, basically a computer vision model, to accelerate surgical robotic education, but also potentially, as you're a resident or surgical trainee, or even just a professional surgeon about to do something, the robot can help kind of correct you, kind of like Tesla's self-drive, but for surgeons.
I mean, technology is exciting, and if we work for it, I worry. But if we are using it to help us get better, I think we're going in the right direction. The other thing I can't resist saying is Hopkins is an incredible place, and the engineering expertise and the collaborative opportunities here are really something. And so it doesn't surprise me that the person who was randomly, standing next to you ended up being a person with a lot to contribute, and that's one of the wonderful things about being a part of this university.
Definitely. It's one of the reasons I came back was two things. One is to experience those frustrations you're talking about, because, on the other side of frustration is opportunity, right? Like if you get frustrated, why are we doing something this way? Like this could be better. If, that's obviously a very common experience anyone has, especially people going down this path of medicine. But if you pause and turn that frustration into why, curiosity, opportunity, that's where I think innovations come from. Probably you've been doing this for many years. Your dad certainly did this about the Whipple. But the second is the people, right? Like obviously you're interacting with the right set of people at the right set of time. That's where innovations also come from. Nobody's doing this alone. So, which I want to ask you about mentorship. So you had worked with Saul Snyder, I assume was a good mentor, but tell me about your mentors, anyone you want to call out, what made them good mentors? And then I'm sure you have mentees. How do you like to be a good mentor? Any advice for other mentors?
I'll mention two quickly. So you brought up Saul Snyder, who was a basic scientist, a psychiatrist by training, and then the head of the neuroscience department. And I did a PhD laboratory experience with him, and Saul was an incredible mentor. Besides being a warm and caring, wonderful person, besides having an incredibly agile mind, he just would teach us how to ask important questions, but ask them in a way such that the answer was going to be interesting and important, no matter which way the science turned out. It was not about hoping for a certain result. I hope that nature is this way. It would be great if it were this way. We could publish a paper. That's really not the way Saul approached things. It was more, there is an interesting phenomena here. It is important no matter how it works out. Let's just try and characterize that phenomena. And that led to a lot of very productive research. And I really enjoyed the 3 years as a graduate student, just sort of letting my mind wander through these interesting series of questions. But there was also a rigor to it too. How do we ask a question in a certain way such that we will have this answered in a definitive way that is publishable, that is helpful to people, that will advance the field? And that was really valuable training. The other very valuable training experience I had was maybe a little more tangible or concrete, and that was learning how to do liver transplants. And I did that out in Southern California at UCLA with a surgeon, Ron Busatil, who had done more liver transplants than anybody who'd ever lived except Tom Starzl. And almost in a flipped script, we had a very set way to do liver transplants. And there was sort of a way you could learn a fail-safe method of doing that very complicated surgery, which was extremely attractive. Liver transplants are hard and they can go sideways and they can be a mess. And it was really, really helpful to learn a system or a systematic approach to doing that operation, which just, continues to serve me and more importantly, my patients well as you embark on any given hard or easy liver transplant. So it was really something to move to California to work with Dr. Busatil for a couple of years and to learn how to do liver transplants or how to approach a liver transplant, the same way every time so that no step got skipped and so that you didn't find yourself in, uncharted waters that you weren't comfortable with.
Yeah, those are wonderful people to have worked with. The Saul Snyder story reminds me of a great quote. I think it was Einstein, one of these amazing physicists, maybe Feynman or Einstein, which is if you have an hour to solve a problem, you spend the first 50 minutes formulating the right question and
Yeah,
then 10 minutes to actually
exactly.
solve it. It just kind of flows from there.
Exactly. I'll go with that for sure. Now we're trying to help young people find their way. And so, that's exciting too. And, I think it's mostly about listening to people. I don't really tell people, well, this is what you should study, or this is what I think is interesting. I don't think that'll work. I think people need to come to it with their own energy. This is what I think I'm interested in. We certainly can help channel that. We can help facilitate that. We can guide that. We can try and help them avoid obstacles, pitfalls, mistakes that we've made. But it comes from them. This is what I'm interested in. This is what I think I'd like to study. Can you help me get where I'm going? But it's where you're going. That is going to be. It's what's going to drive you rather than somebody externally saying, "I figured it out. This is what you ought to study." I don't think that's going to work. And most young people come to the discussion with very sophisticated understandings of what they want to study. With their exposure to patients or their exposure to the internet or the sort of global village of knowledge now. People know what they want to do and often come to discussions with more information than I am.
Yeah, that willingness to learn and listen, I was impressed with in the whole surgical clerkship. Dr. GK, who's wonderful, you think the world of her too, said in her first lecture to us when we were starting the surgical clerkship that, statistically, most of us aren't going to be surgeons, but leveraging these 8 weeks, these 2 months to understand what our patients are going through, because many of them that we're treating, whatever field we go into, have either had a past surgery or preparing for surgery or are currently being treated for post-surgical. So that was one. And number two, it's like, just be a kid again, like have a sense of wonder. And, I did this where I was on the urology surgeries, but I decided to like instead of doing the same surgery again, go and check out what cardiac looks like for transplant, because I may never, if I don't do surgery, I may never be able to do that again. So I think that's pretty cool.
I just wonder if we'd all be better off in this world understanding better what our brothers and sisters are going through. So to your point, even if you're not going to be a surgeon, you got 8 weeks trying to understand what's going on here. You'll be a better internist or psychiatrist. That goes for us too. Do we understand what it's like to be an anesthesiologist? And the more I think we can all walk a mile in one another's shoes, the more we can do our own jobs better, and the more these teams can function better. And I think that's obviously is where not only medicine is going, but where it already is. It's really a team sport, and we all work together. And the better we work together, the better the results for the patient.
Yeah. And one of the things it's a good transition to this. One of the things I really enjoyed about being in your office was looking at your bookshelf, because one of the best ways to walk a mile in somebody else's shoes, or put another way, to gain decades of wisdom without gaining decades of age, is to just read biographies and read what other people have written, their best thoughts, right? Because that's what gets through the publishing protocols. And so I would love to hear one or two book recommendations, anything super influential you want to share. You had everything from meditations to principles and tons of biography. I think Grant was on your shelf. Yeah, I would love to hear what struck you.
Just finished Confederacy of Dunces. I enjoyed that quite a bit. Now, I have to admit, I read that because my 10th grader is reading it. So I spend a lot of time revisiting the classics with my kids. And on the less pleasant side, I'm relearning organic chemistry now too. So
Why? How come?
because my daughter is a freshman in college.
Okay.
There's some good and there's some bad. But I would say reading and travel. Just get out there, understand the bigger world. When we're exposed to people very different from us, it can't help but be enjoyable and enlightening, and remind us, of our smallish place in the universe. And it's humbling, and it's mind expanding. And maybe on a smaller scale, every time we meet a patient, they've got a story that they tell us. And we don't know what it's like to be them. We don't know what it's like to be sick. We don't know what it's like to be vulnerable. And, I think remembering that helps us take good care of them, regardless if it's going to be a surgery or not.
Yeah. Stretch your mind in new dimensions. We're coming up in time. So the last two questions I have, one is I want to, we're talking about books, talk about your book, which is excellent. Thank you again for the copy, Current Surgical Therapy, which I think you're going to have a 15th edition coming out in the next couple of years. And it's published by Elsevier, which I know well from Osmosis, as acquisition by them. Tell us about your experience as an author. What gets you excited about that book and that role?
It's an interesting book. It's was started by my father, 30 years ago. And it's an interesting thing because it is a general surgery book. It covers every topic under the sun, and it comes out, interestingly, every 3 years. So rather than a definitive textbook in which you would go and read a 20-page chapter on appendicitis or, thyroid cancer, it is rather a current expert's quick take on that topic. And so somebody may say, here's what's new with colon cancer. And then it's a 3 or 4 page chapter. And the idea is it's something that a resident or a junior faculty member could handle, rather than being a definitive introduction to a topic for somebody that's never heard of it before. And it comes out every 3 years, which is interesting because if you keep up with it and have a couple old editions on your shelf, if there's a topic that comes to mind, pancreatitis, you can open the last couple editions and read 3 experts' different takes on that topic, and pretty quickly accrue a knowledge of the current thinking on that topic, as if you had just witnessed a debate amongst experts. So it's been a pleasure really serving as co-editor of that text. And what that allows us to do is every 3 years, we reach out to 300 experts across heterogeneous fields of surgery, ask them to contribute a chapter. They send them in, and me and my father go through and read them all. And that's an excellent reintroduction, to diverse fields of surgery every few years. So it keeps us current.
Yeah, that's the name of the book, and I think most residents and surgeons I've met have cited it as the go-to for being able to complete their training and stay fresh and current. Last question for you: any parting words of wisdom, advice you want to share with our audience, and an open mic? Anything else you want to share before we let you go?
Well, I would say, we thank you for your time, Shiv, and thanks for having me on the show. And you're very generous, and we spent the last 30 minutes or so sort of talking about what has captivated me, or what I found interesting. And I would say to young people, forget all that. You don't need to worry about a minute of that. Find out, follow your nose. What is your passion? What is it that speaks to you? And if you approach that, you will never work another day in your life. That passion, at least in our field, is directed towards helping people. It is finding that unmet need where there is still suffering, where there is still ineffective medical care, and saying, I can pitch in on that. I bet I could help on that. That all comes, from that commandment, which is love your brother. Almost love your brother, love your sister. You're gonna travel the halls of the hospital, and you're gonna see fellow human beings in need, suffering. And if that speaks to you, you're going to want to try and help them. That may require sitting down and talking to them. That may require retreating to the laboratory to understand what the problem is. It may require understanding the newest technologies which are changing the world to try and help them. But it is that interest in making this world a better place, following your own nose, your own passions, that are going to sustain you, over a long and successful career, and keep you happy and keep you young.
Well, those are some wonderful words of wisdom. And Dr. Cameron, I want to thank you for taking the time to be with us on the Raise Line podcast, and more importantly, for what you've done to raise line and strengthen our healthcare system.
My pleasure. Good seeing you.
Good seeing you as always. And with that, I'm Shiv Glani. Thank you to our audience for checking out today's show. And remember to do your part to raise line and strengthen our healthcare system. We're all in this together. Take care.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisethelinepodcast.